to Storm Anesthesia's Anesthesia for Post-Anesthesia Care Nurses. This is a 7-video series on the basics of pharmacology and anesthesia techniques for the Perianesthesia Care Nurse. We, a group of 5 outstanding senior students from the University of South Carolina School of Medicine Nurse Anesthesia Program and 1 CRNA, have created this series in the hope it will help the transition into the perianesthesia world. The series attempts to shine a bit of light on the techniques anesthesia uses during surgery, as well as explain the basics of the pharmacology behind our drug uses. This is by no means a series that will explain everything that happens during anesthesia, but our hope is that you, the perianesthesia nurse, will find our report a little less intimidating and a little more informative. After all, the better you understand the report, the better you can take care of the patient. And ultimately, this will increase the safety and satisfaction for both your patient and yourself. The group consists of Alexandra Horman, BSN RN, CCRN, Braden Seidler, BSN RN, Jordan Coleman, BSN RN, CCRN, Kelsey Squires, BSN RN, CCRN, Victoria Koch, BSN RN, and Michael Storm, DNAP, CRNA, CCRN. The videos can be watched separately, but there are some references among the videos and the basics of the pharmacology along the way. Therefore, it may be beneficial to watch the series in order. Either way, have fun and don't forget to download the accompanying handouts. These handouts are the complete transcripts of the narrations and include all relevant pictures from the videos. This video series is sponsored by Storm Anesthesia and Palmetto Health Richland Anesthesia Department. Enjoy and let's get started.
Hello, my name is Victoria Koch. I am a registered nurse and a senior master's student in the anesthesia program at the University of South Carolina, and today I would like to talk to you about local anesthetics. The objectives for this presentation are to discuss the clinical use of local anesthetics, explain the physiological processes of how local anesthetics work, distinguish between commonly utilized local anesthetics, and discuss some of the complications of local anesthetics and the treatment of these complications. Local anesthesia is defined as the reversible loss of sensation in a limited area of the body without loss of consciousness by the use of a chemical agent. This form of anesthesia can also be referred to or thought of as local analgesia, as it blocks the pain transmission. Local anesthesia has the ability to produce desensitization and analgesia of the skin, known as topical anesthesia, tissues, known as infiltration and field block anesthesia, and regional structures, referred to as neuraxial, conduction, and peripheral nerve block anesthesia. Now let's examine some formal definitions associated with local anesthesia. Conduction block anesthesia is when local anesthetic is injected in the immediate vicinity of a major nerve plexus, such as the brachial plexus, lumbar plexus, and neuraxial anesthesia. Field block anesthesia is when local anesthetic is injected in a fan-like manner into tissue surrounding an incision or puncture site. Infiltration anesthesia is when local anesthetic is injected into the area of terminal nerve endings. Intravenous anesthesia is when general anesthesia is produced by the injection of local anesthetics and other anesthetic agents into the venous circulation to cause central nervous system depression. Neuraxial blockade is a generic term that encompasses both spinal and epidural anesthesia. Peripheral nerve block is when local anesthetic is deposited in the immediate vicinity of an individual nerve to produce anesthesia. Topical anesthesia is when local anesthetic is applied to the skin or mucous membranes, including the pharyngeal cavity or urethra. Systemic absorption from the mucous membranes is rapid. Excessive dosing can lead to toxicity. Why use local anesthesia? There are several reasons why one would opt to incorporate local anesthesia into their surgical process. For starters, local anesthesia can provide effective analgesia. This is beneficial as it helps decrease the use of postoperative narcotics and non-opioid analgesics. Consequently, the use of local anesthetics helps decrease postoperative pain, thus aiding in patient satisfaction. Local anesthesia, when used on its own without the addition of general anesthesia, has the ability to reduce recovery time, as one does not have to wait for a patient to fully wake up, as they may not require any sedation at all to perform a procedure. This facet, in conjunction with the formerly mentioned pain relief provided by local anesthetics, can get individuals up and moving around sooner. The use of local anesthesia has the ability to decrease the body's stress response to surgical trauma by blunting pain and the pain response at the surgical site. Finally, the use of local anesthesia has the potential to reduce central sensitization. Central sensitization is a condition of the nervous system that is associated with the development and maintenance of chronic pain. When central sensitization occurs, the nervous system goes through a process called wind-up and gets regulated in a persistent state of high reactivity. This makes an individual more susceptible to chronic pain, which is harder to treat. Local anesthetics can disrupt the transmission of these nerve impulses, thus helping reduce the development of central sensitization. The use of local anesthetics is equipped with both advantages and disadvantages. Local anesthetics can be used as a standalone anesthetic/analgesic or in conjunction with general anesthesia. Local anesthesia, when utilized by itself, has a lower cost than general anesthesia. Additionally, the use of local anesthesia can decrease the use and thus cost of narcotics. It is suitable for awake patients, so is a great option for outpatient surgery. Local anesthesia can decrease the time one spends immobilized, therefore helping decrease the risk of deep vein thrombosis, known as DVT, in the post-surgical setting. There are, however, some disadvantages to the use of local anesthetics. In order to achieve success with the use of a local anesthetic, you must have a cooperative patient. For this reason, a patient may still require sedation in conjunction with the use of local anesthetics. Additionally, although infrequent, local anesthetics do have the ability to be irritants or cause some negative side effects such as lightheadedness, muscle twitch, or headache. Mechanism of action. Local anesthetics work at the level of the sodium channel to prevent action potentials from occurring. Depicted on the left is a single action potential. This process occurs at the axon. The axon is a long, slender projection located on the neuron or nerve cell membrane. Each neuron has a designated negative resting membrane potential. The resting membrane potential is maintained by the sodium-potassium pump, which helps balance the influx and efflux of positive sodium ions and negative potassium ions in and out of the cell. Now let's look at a single action potential illustrated by this picture. Out, at the top of the picture, is the outside of the cell, and in, at the bottom of the picture, is the inside of the cell. The large yellow circle is the sodium channel, and the small yellow circles are the sodium ions. The large orange circle is the potassium channel, and the small orange circles are the potassium ions. As you can see, there is a preponderance of sodium ions outside the cell, denoted by the yellow circles, compared to the potassium ions, and vice versa for inside the cell, more potassium and less sodium. In this picture, both the sodium and potassium channels are closed. The only movement of ions happens through the sodium-potassium pump. This pump is the large green circle. This energy-driven pump pumps sodium ions out of the cell and potassium ions into the cell. This action requires energy since the ions are moving against their concentration gradient. For example, sodium ions are plentiful outside of the cell, and the sodium-potassium pump moves even more sodium ions out of the cell, and potassium ions are plentiful inside the cell, but still more are moved back into the cell. Since this movement goes uphill, so to speak, it requires energy. Now let's break down the steps of the action potential. In the graphic above, the resting membrane potential is -70 millivolts and is designated in this picture as step 1 of the action potential. As previously discussed, the resting membrane potential is maintained by the sodium-potassium pump, which keeps this balance by regulating the movement of positive sodium ions and negative potassium ions in and out of the cell. A stimulus such as pain causes the influx of positive sodium ions into the cell. This alters the membrane potential, making it less negative. This process is called depolarization. The influx continues until the neuron reaches its threshold. Threshold is the level at which an action potential can be triggered. In this example, the threshold of the neuron is depicted via the red dotted line and is -55 millivolts. Upon reaching threshold, the action potential is set in motion and cannot stop until completion. The neuron rapidly depolarizes with the influx of sodium ions via voltage-gated sodium channels until reaching its peak. This process is denoted in the picture above as step 2 of the action potential. Upon reaching its peak, the membrane potential begins to repolarize or become more negative. This process occurs through the influx of potassium ions through the voltage-gated potassium channels and is depicted above as step 3 of the action potential. The neuron continues to repolarize until it falls below threshold once again and reaches its resting negative membrane state, denoted by step 4 in the action potential above. It then maintains this state via the sodium-potassium pump until another stimulus reinitiates the process. Consequently, to prevent an action potential, local anesthetics must block voltage-gated sodium channels. By blocking voltage-gated sodium channels, the neuron is prevented from depolarizing and thus prevented from reaching threshold, rendering it unable to trigger an action potential. Depicted here is a larger scale view of the physiologic processes we discussed on the last slide. Box A depicts a single sensory neuron in the body. Here we view the presence of nociceptors at the end of the neuron body. Nociceptors are a type of receptor located at the end of the neuron. Nociceptors sense and send signals of pain to the spinal cord and the brain. Local anesthetics achieve blockade by impeding the transmission of the message of pain from nociceptors to the spinal cord and brain. This is achieved by inhibiting the influx of sodium ions through the selective voltage-gated sodium channels of the membrane as depicted in pictures B and C. By inhibiting sodium ions, there is an impairment of the generation of the action potential as a whole, and thus a stop of the conduction of nerve impulses. The prevention of these nerve impulses prevents the message of pain from reaching the brain. Local anesthetics can be classified by their chemical structure, duration of action, and potency. In terms of chemical structure, local anesthetics can either be classified as an amino ester or an amino amide. Amino esters are derived from benzoic acid, whereas amino amides are derived from aniline. The differences between these two chemical structures is depicted on the left-hand side of your slide. Ester local anesthetics include procaine, chloroprocaine, benzocaine, cocaine, and tetracaine. Amide local anesthetics include bupivacaine, MEPIVACAINE, ROPIVACAINE, LEVOBUPIVACAINE, LIDOCAINE, and PRILOCAINE. To quickly differentiate whether a local anesthetic is an ester or an amide, note that there are two I's in the amide agents, such as bupivacaine. In addition to chemical structure, local anesthetics can be classified by their potency and duration of action. As indicated in this table, low potency, short duration of action local anesthetics include drugs such as procaine and chloroprocaine. Intermediate potency and medium duration of action local anesthetics include MEPIVACAINE, LIDOCAINE, and PRILOCAINE. High potency and long duration of action anesthetics include bupivacaine, ROPIVACAINE, and ETIDOCAINE. It is important to understand these distinctions when caring for your patient so that you can anticipate the onset of symptoms associated with the wearing off of local anesthetic, as well as be proactive in treating pain. There are two major factors that affect the activity and potency of local anesthetics: lipid solubility and protein binding. If a local anesthetic has increased lipid solubility, it will have a decreased or slower onset of action. Local anesthetics that are highly protein bound have a longer duration of action. These concepts are important to keep in the back of your mind as we discuss individual local anesthetics as short, intermediate, and long-acting, as well as their potency as a drug. Pharmacokinetics. Pharmacokinetics is the study of how drugs move in the body. This includes how drugs are absorbed, metabolized, and excreted. As mentioned in the previous slide, drugs with greater lipid solubility and protein binding will have a slower onset and longer duration of action. This can also be thought of as lower systemic absorption. Ester and amide local anesthetics are both metabolized and excreted in different ways in the body. Ester-linked local anesthetics are metabolized by nonspecific plasma pseudocholinesterase. Esterase is present in the liver, red blood cells, and synovial fluid. Ester anesthetics are excreted as metabolites in the urine. Amide-linked local anesthetics are almost exclusively metabolized by the liver by microsomal enzyme CYP450. Similar to ester-linked local anesthetics, amide-linked local anesthetics can be excreted as metabolites in the urine, but are also excreted as metabolites in the bile. Amides. Amides include lidocaine, prilocaine, mepivacaine, bupivacaine, ropivacaine, levobupivacaine, and ETIDOCAINE. Amides are metabolized by the liver and are rarely thought to cause allergic reactions. Lidocaine. Lidocaine is an intermediate-acting local anesthetic. It has a quick onset and is very potent. This is because lidocaine is highly protein-bound. It is because of this strength that lidocaine can be accompanied by side effects of dizziness and sleepiness. To help combat these side effects, lidocaine is frequently administered with epinephrine to decrease the vasodilation and absorption of this drug. The co-administration of epinephrine also helps prolong the duration of action of local anesthetics, and thus is commonly co-administered with other local anesthetics as well. Lidocaine, which is typically effective between 40 and 90 minutes, can last up to 240 minutes when administered with epinephrine. The maximum dose of this medication without the use of epinephrine is 4 mg per kg and increases to 7 mg per kg with the use of epinephrine. Lidocaine is metabolized by the hepatic microsomal enzymes such as CYP450. This means that one should exercise caution when administering lidocaine to a patient who takes medications that either decrease hepatic blood flow or inhibit metabolic enzymes. Some of these drugs include propranolol, cimetidine, and SSRIs. It is frequently utilized in spinal anesthesia as it possesses the ability to block both sensory and motor nerves equally well. Additional uses of lidocaine include the treatment of re-entry tachyarrhythmia. In this instance, the ischemic portion of the ventricle is damaged and does not conduct action potentials as rapidly as the healthier portion of the heart. It will eventually lag behind to the point that it begins firing signals on its own very rapidly. IV lidocaine targets the ischemic portion and will block conduction to bring it back into sequence with the rest of the ventricle. PRILOCAINE. PRILOCAINE is a short-acting, intermediate potency amide. This local anesthetic has the duration of action of approximately 60 minutes, or 380 minutes when administered with epinephrine. The maximum dose of PRILOCAINE is 5 mg per kg and increases to 7.5 mg per kg with the addition of epinephrine. It has a less vasodilatory effect than lidocaine and is metabolized in the blood. Once absorbed in the blood, PRILOCAINE releases a chemical compound called orthotolididine. This substance converts hemoglobin to methemoglobin. Consequently, PRILOCAINE has the ability to cause methemoglobinemia. Symptoms of methemoglobinemia include brown-gray cyanosis, tachypnea, metabolic acidosis, hypoxia, headache, irritability, and chocolate-colored blood. Methemoglobinemia can be treated with methylene blue injection of 1 to 2 mg per kg. This dose can be repeated if necessary. MEPIVACAINE. MEPIVACAINE is an intermediate-acting local anesthetic. This local anesthetic, similar to lidocaine, has moderate potency and toxicity. However, it does not cause the same vasodilatory effects as lidocaine. MEPIVACAINE can provide local anesthesia for 60 to 120 minutes and can last up to 360 minutes when administered with epinephrine. The maximum dose without epinephrine is 5 mg per kg and increases to 7 mg per kg with the addition of epinephrine. MEPIVACAINE is metabolized by hepatic microsomal enzymes. Consequently, similar to lidocaine, be aware that patients taking medications also metabolized by these enzymes are at risk for having a prolonged duration of action with this local anesthetic. MEPIVACAINE is utilized in both epidural and caudal anesthesia. However, unlike lidocaine, MEPIVACAINE is not frequently utilized in spinal anesthesia, as its use is associated with an increase in incidence of transient neurological symptoms. Transient neurological symptoms include intense pain in the buttocks and thighs and sometimes radiates to the lower extremities. It begins within 24 hours of spinal anesthesia and can last as long as 10 days, but typically resolves within 48 hours. Bupivacaine. Bupivacaine is a long-acting local anesthetic that is 4 times more potent than lidocaine. As a result, the residual analgesia of this medication outlasts the anesthetic, providing a longer course of pain relief for the patient. This medication provides a greater sensory block than motor block and is commonly utilized in both spinal and epidural anesthesia due to its long duration of action of 120 to 240 minutes and as long as 8 hours with the addition of epinephrine. The maximum dose of bupivacaine is 2.5 mg per kg or 3.2 mg per kg with the addition of epinephrine. The maximum single dose is 175 mg, and it is recommended to not exceed 400 mg over the course of 24 hours. Like formerly mentioned amides, this local anesthetic is also metabolized by hepatic microsomal enzymes. Caution: when utilizing this drug, one needs to be aware of the potential cardiovascular side effects that can occur at higher doses or, in the case of an accidental IV injection, which could leave your patient with severe hypotension or a ventricular arrhythmia that might not be easy to correct due to bupivacaine's long duration of action. ROPIVACAINE. ROPIVACAINE is a long-acting local anesthetic with intermediate potency. Its chemical structure is very similar to bupivacaine, resulting in a similar projection for the way this local anesthetic works in the body. However, ROPIVACAINE is associated with less cardiotoxicity and less motor block than bupivacaine. Ropivacaine is frequently utilized in epidural anesthesia and can have the duration of action of approximately 3 hours or up to 6 hours when administered with epinephrine. The maximum dose of ropivacaine is 2 to 3 milligrams per kilogram. LEVOBUPIVACAINE. LEVOBUPIVACAINE is an intermediate-acting local anesthetic. It has a similar chemical structure and drug profile to bupivacaine, but is not associated with the cardiodepressant effects that can sometimes accompany bupivacaine. It has a fast onset of less than 15 minutes, and the duration of action can last upwards of 9 hours and as long as 12 hours with the addition of epinephrine. This local anesthetic is frequently injected in conjunction with an additive for additional pain relief, such as fentanyl, clonidine, or preservative-free morphine. The maximum dose of levobupivacaine without additive is 2 milligrams per kg, or 400 milligrams over the course of 24 hours. ETIDOCAINE. ETIDOCAINE is a long-acting, high-potency local anesthetic. To achieve sensory block with this local anesthetic, it requires an extremely high concentration. It is utilized as a local injection in peripheral nerve blocks and in epidurals due to its long duration of action of 4 hours and up to 8 hours with the addition of epinephrine. The maximum dose for ETIDOCAINE is 2.5 milligrams per kg or 4 milligrams per kg when administered with epinephrine. Esters. Now we will continue our discussion of local anesthetics, focusing on the ester group. Esters include cocaine, procaine, chloroprocaine, TETRACAINE, and BENZOCAINE. Cocaine. Cocaine was the first ester class drug used in the clinical setting in 1884. It is a strong topical anesthetic and is utilized in anesthesia especially for its vasoconstrictive properties. For this reason, it was previously utilized for the nasal mucosa before nasotracheal intubation and during nasal operations. Although still available, this local anesthetic is no longer frequently used due to the high risk for abuse potential and availability of other vasoconstrictors such as aspirin spray and phenylephrine. Cocaine has the duration of action between 5 and 90 minutes. It is metabolized by the liver, and its metabolites are excreted in the urine. This local anesthetic blocks the reuptake of catecholamines and consequently causes an accumulation of norepinephrine in the synaptic cleft. This leads to profound effects in the central nervous system. At low doses, it will cause stimulation, restlessness, euphoria, and talkativeness. In moderate doses, it can cause tremors, convulsions, and emesis. And in high doses, it can cause CNS stimulation, marked by high heart rate and blood pressure, followed by CNS depression and increased body temperature. Procaine. Procaine was the first synthetic ester class local anesthetic. Created in 1904, it is less potent and shorter acting than its amide counterpart, lidocaine. Procaine is reported to cause more allergic reactions than lidocaine. It is not effective topically, but can be utilized in spinal anesthesia, peripheral nerve blocks, and local infiltration anesthesia. To help slow absorption, it is commonly administered with a vasoconstriction agent such as epinephrine. This also aids in diminishing the chance for a systemic toxicity when administering this drug. The duration of action of procaine is 20 to 60 minutes and up to 90 minutes with the addition of epinephrine. There is a maximum dose of 8 milligrams per kg or 10 milligrams per kg when administered with epinephrine. Procaine is metabolized by plasma cholinesterase. CHLOROPROCAINE. CHLOROPROCAINE is a short-acting local anesthetic. It has a rapid onset and is utilized in infiltration, peripheral nerve blocks, and caudal/epidural anesthesia. CHLOROPROCAINE provides a stronger sensory than motor blockade and can last up to 60 minutes or as long as 90 minutes with the addition of epinephrine. The maximum dose of CHLOROPROCAINE is 10 milligrams per kg or 15 milligrams per kg with epinephrine. It is metabolized by plasma cholinesterase. Administration of this drug can be associated with thrombophlebitis, a condition in which blood clot forms in the vein causing inflammation and pain. Symptoms include redness, swelling, tenderness, warmth, and tenderness at the affected site. Treatment includes elevating the site, cold or warm compresses, and anti-inflammatory medications. TETRACAINE. TETRACAINE is a long-acting, high-potency local anesthetic. In fact, TETRACAINE is 10 times more potent than PRILOCAINE. This medication is effective topically and causes an extensive motor and sympathetic blockade. For this reason, it is commonly utilized in corneal anesthesia. Its duration of action is 2 to 3 hours or 10 hours with epinephrine. The maximum dose is 1.5 milligrams per kg or 2.5 milligrams per kg with epinephrine, and it is metabolized by plasma cholinesterase. BENZOCAINE. Our last local anesthetic is benzocaine. This local anesthetic is only effective topically as it exists only in a non-ionized form, which is atypical of local anesthetics. Other local anesthetics are made up of several elements that combine to make the drug. The end result leaves the drug without a minus or plus charge. If these drugs can be ionized, they split into parts. One of the parts carries a plus charge, while the other part carries a negative charge. A simple example is table salt, or sodium chloride, which can be ionized in water. Sodium chloride is an inorganic compound. When table salt is placed in water, it is able to ionize or divide into ions of positive sodium and negative chloride. Non-ionized drugs, on the other hand, such as benzocaine, are organic compounds that cannot separate or divide. The molecules are stuck in their structures together in such a way that they cannot separate into parts. It is for this reason that benzocaine is effective as a topical anesthetic, as it will not be broken down into parts. The typical duration of action for this local anesthetic is 30 to 60 minutes. Possible side effects. Now let's discuss some of the side effects of local anesthetics, which can include central nervous system toxicity, cardiovascular toxicity, and neural damage. Central nervous system toxicity. Hypercarbia and hypoxia can potentiate CNS toxicity. Therefore, it is important that after receiving local anesthetic, your patient maintains an appropriate oxygen saturation level. CNS toxicity can sometimes be avoided with the application of supplemental O2. Symptoms of CNS toxicity include circumoral numbness, this is typically an early symptom, lightheadedness, tinnitus, visual disturbances, slurred speech, muscle twitching, irrational speech, apnea, which is followed by cardiovascular depression, grand mal seizures, which should be treated with Versed and Valium, and finally, coma. It is important to monitor your patient closely and notice these symptoms early on. Cardiovascular toxicity. Although uncommon, cardiovascular side effects are among the hardest complications associated with local anesthetics to treat. This is because local anesthetics competitively block the sodium channels of the heart. Cardiovascular toxicity is most commonly associated with the administration of bupivacaine and tetracaine. Signs and symptoms include hypertension that leads to hypotension, premature ventricular complexes, prolonged PR interval and QRS complexes on EKG, and ultimately cardiovascular collapse. The first-line treatment is prevention. Local anesthetic should be initially injected in divided doses with frequent aspiration to prevent the possibility of cardiovascular toxicity. If cardiovascular toxicity should occur, hypotension should be treated with ephedrine. One should be prepared to provide advanced cardiac life support with the possibility of transcutaneous pacing. The use of 20% intralipid infusion to the site of regional anesthesia can also offer some protection from the progression of cardiovascular collapse. Lipid rescue. In the event of a local anesthetic-induced cardiac arrest that is unresponsive to standard therapy such as advanced cardiac life support protocol drugs, in addition to standard cardiopulmonary resuscitation, intralipid 20% should be given intravenously. Throughout the lipid rescue, it is important to maintain CPR efforts with limited interruptions. Administer an intralipid 20% bolus at a rate of 1.5 milliliters per kg over 1 minute. This bolus dose can be repeated every 3 to 5 minutes, up to a dose of 3 milliliters per kg in total until circulation is restored. After the initial bolus, continue with an intralipid infusion at a rate of 0.25 milliliters per kg per minute. After circulation is restored, continue the infusion, increasing it to a rate of 0.5 milliliters per kg per minute for drops in blood pressure. Neural toxicity. The spinal cord and roots are most prone to neural damage. Additional neural side effects include transient radicular irritation and cauda equina syndrome. Transient radicular irritation is associated with the administration of lidocaine. It typically presents within 24 hours and can last up to 1 week. Symptoms include pain in the buttocks, lower back, and posterior thigh pain. Cauda equina syndrome, CES, is associated in descending frequency with lidocaine, tetracaine, bupivacaine, and ropivacaine. This is an injury to the lumbar sacral plexus and sensory paresthesia. Symptoms include bowel and bladder dysfunction and paraplegia. Conclusion. Local anesthetics are utilized in a wide variety of anesthesia, including conduction block anesthesia, field block anesthesia, infiltration anesthesia, neuraxial blockade, peripheral nerve blocks, and topical anesthesia. Local anesthetics work by inhibiting the influx of sodium through voltage-gated sodium channels, thus preventing action potentials in the body. Local anesthetics can be used to provide standalone analgesia or in conjunction with general anesthesia. The duration of action and potency of local anesthetics varies with the drug's lipid solubility and affinity for protein binding. Local anesthetics are divided into 2 classes, AMIDES and ESTERS. AMIDES include PRILOCAINE, LIDOCAINE, MEPIVACAINE, BUPIVACAINE, ROPIVACAINE, LEVOBUPIVACAINE, and ETIDOCAINE. Esters include cocaine, procaine, CHLOROPROCAINE, TETRACAINE, and BENZOCAINE. Although uncommon, central nervous system, cardiovascular, and neural toxicity is possible with local anesthetics. Local anesthetics are widely used to provide analgesia in a wide array of patients and procedures. This concludes my presentation on local anesthetics. Thank you for your continued work in caring for our patients and your time.
We hope you have enjoyed this 6th lecture in the series. We have created a 7-lecture series covering many techniques used in anesthesia. We have specifically focused on the need of the PACU-RN and hope you will find time to view the other 6 lectures as well. The lecture series includes this lecture, Local Anesthetics, and the following 6 lectures: Basic Principles of Pharmacology, Inhalation Anesthesia, Non-Opioid Intravenous Anesthetics, Opioid Intravenous Anesthetics, Neuromuscular Blocking Agents, and Regional Anesthesia. All lectures are available on the Palmetto Health intranet as well as on stormanesthesia.com/education/PACU/PACU-videos.